Okay, so could you tell me a little bit about yourself and your position at UT?
Sure. My name's Stephanie. I've been a social worker since 2007. I have a history of being an investigator at Child Protective Services. I've worked in the pediatric department at Children's Memorial Hermann Hospital and the Med Center. And then I worked at Texas Children's as well. And now I'm here in the UT Care Clinic. Basically, our clinic, the focus of the children that we see is primarily abuse and neglect or at risk of abuse or neglect.
Okay.
And basically in the clinic here, we see a lower number of patients so that we can be more focused on them, provide more support. We do have counseling here, psychiatry, social work obviously, and then medical staff.
Okay. And how do you get referrals to you?
So our team, the care team, which is made up of mostly doctors, they actually will see patients at Children's Memorial Hermann Hospital, and then a lot of the referrals come from them, Child Protective Services, or other clinics here in UT.
Okay. Okay. And out of those referrals that you do see, what is the most common child maltreatment that you find?
The most common is definitely neglect.
Okay.
Not having things at home. Medical neglect is a big one. And a lot of times for medical neglect kids, they might not even have CPS. We're just trying to keep an eye on them, make sure that the parents are able to have compliance for medical needs.
Right. And so what would that look like, I guess, a little bit in like, so they take the child to the doctor at Memorial Hermann, and then are the doctors just like, oh, well, we haven't seen you in a while, or oh, we noticed that these kids' teeth are rotten, or what sort of stuff?
Usually, a lot of the kids in the ICU, our team will see, and some of that could be physical abuse or sexual abuse. Sometimes it might just be family dynamics, maybe mom and dad, there might be some domestic violence that happens on the unit. And then the team in the hospital, your typical doctors, will then consult our team. And our doctors have more of an assessment that seems like a psychosocial assessment mixed with a medical visit. And if they feel like the child needs to be seen further in the community, that's how we'll get the referral.
Okay. And then do you, based on like Texas state law, do you think that the law is all-encompassing of abuse that occurs, or is there a lot that you've noticed slips by, or what are your thoughts on that?
I feel that for the most part it's all-encompassing. You know, as far as physical abuse goes, you can spank your child with your hand or a belt on the bottom. In the state of Texas, no other part of the body. Any marks or bruises even included on the bottom is deemed physical abuse.
Okay. And have you noticed, like when I was doing research on this topic for child physical abuse, it mentioned a lot about like how cultural differences come into play a lot, and like what that looks like of, oh, well, we're just disciplining our child, we're not abusing them. What are some of the, I guess, do you come across that?
Culturally, not necessarily, but I would say you get a lot of, oh, I was spanked as a child, or this is how I was disciplined as a child, and I'm fine.
Yeah.
And so that's more the idea, I would say, that they have maybe more generational than cultural.
That's interesting, because even when I was doing the research, I was thinking, like, because it's like, oh, some could be cultural differences, I was thinking, oh, in Houston, it could be a lot of that, because like it is so culturally diverse, and you know, all different people coming from all different areas, and so that's just really interesting that you said that. I was like, oh, like for sure this will be.
What's an example of what you saw in your research?
So just like they said, like sort of, I guess what you were saying, like, oh well, I was hit as a child, or well, we used to make our kid, or like I was made to like do these, I guess more like child labor almost, like do these sort of things as children, and like my mom and dad still loved me, and like I turned out okay, so what's the difference really?
Sure. And I think that you do experience that, like say it's a little more common, say for sexual assault, for a mother to herself have been sexually assaulted as a child, and I'm not really sure why that is, and maybe with some families it's a little more acceptable than others, but I haven't seen, as far as culture goes, that that's a factor.
Interesting. And then I did another thing that I researched or came across in the research. One article was saying like that it's a lot more common for younger boys to be physically abused than say like older girls in even the same family. Do you notice that in like the referrals or?
With our clinic, no. It's really been across the board, ages, genders, the whole thing. I think there are risk factors when, say, you have a child maybe who has an undiagnosed psychiatric condition, and so they're kind of all over the place. Maybe mom is cognitively delayed or has psychiatric issues herself. You know, not having resources, how are they going to pay the bills, or what food are they eating? I think those are risk factors for sure, but we've really seen physical abuse and neglect across the ages and gender.
Okay. And then you sort of just touched on that, what I'm about to ask, but what are some of the major, or like three of the top like familial risk factors that you've noticed in working with child physical abuse?
I definitely think this is how I was raised, this is, you know, the norm. A lot of cognitive delays in parents is what we've seen here, of they're just not knowing, especially for neglect. Maybe they don't realize what they're supposed to be doing.
It's okay if you don't have it.
I have one. I just didn't write it down. So
we can come back. Or if you forget completely, it's really fun. And then what do you believe is the greatest protective factors that you've seen related to child physical abuse?
Well, definitely law enforcement. For people who do physically abuse their children, there is repercussions to that. We have seen people who get arrested or just have to be investigated by the police. Child Protective Services, how they are able to remove children. Sometimes with physical abuse, it's almost easier to remove a child because you have the physical evidence of the abuse, where say things like neglect or even sexual assault are a little harder to prove sometimes. And then definitely community agencies like ourselves, where we are able to follow up with families even when CPS isn't involved and try to problem solve things ourselves. But we can also get CPS involved when it's just that what we are doing is not working and we just need a little more intervention.
Absolutely. Yeah. And then and you mentioned like the law enforcement getting CPS, and another thing that I again researched or noticed in the research was one of the main, I guess, even risk factors is that there's domestic violence in that home or between a mom or a dad or a mom or a boyfriend. So have you noticed that being, I guess, like a father figure or boyfriend being more likely to be the abuser than even a mom or a like the actual father?
Yes.
Okay.
Yes. Typically it is some sort of a male figure, I would say most of the time. Sometimes when you see that it's mom, it could be because maybe dad isn't involved, or maybe there are several kids and they have different fathers and they aren't involved, and they have a lot that they have to take care of beyond just taking care of the child. And so sometimes they get really, really frustrated and they lose their patience. But most of the time, it could be dad, boyfriend, uncle, grandfather.
Right.
You know, it does happen like that as well.
Yeah. And so in those sort of cases, would it be a matter of like just getting the mom and her children in a safer place, or have you noticed? Okay.
If mom's appropriate, meaning like she's at least trying or getting things that she can, or maybe she's being protective of her child, but maybe she can't afford a house or an apartment or something like that, then usually CPS will intervene and try to scoop mom up with the kids and get them all out.
Okay.
Yeah.
And then I guess a little bit more going back to like what you guys do here. So again, in the research that I had done, two of the like biggest evidence-based practices when working with survivors of child physical abuse was parent-child interactive therapy, and then also abuse-focused cognitive behavioral therapy. I guess I know that you guys don't necessarily use those, and what kind of modalities do you use when a child does come into your clinic and has been a survivor of?
A big part of it is our counselor. If we feel that a child needs to have further therapy, our trauma-focused counselor is able to see the child. She does TFCBT.
Okay.
And that's once a week, getting together with the child, talking about.
Oh no. Let's just make sure it's not going.
Oh. Making sure, seeing them once a week, doing like your typical therapy, talking about the trauma that they experienced, and in the end, doing a trauma narrative with the family. Sometimes that can be the abuser, sometimes that's just who has the child in their home, like a caregiver, that could be a relative, or say a foster parent, and she does TFCBT.
Hold on, I'm sorry. With the narrative, so you're saying that they say the narrative, they come in, so they've done the TFCBT with the counselor once a week for normally how many weeks?
It can usually be about, I would say, around 2 months. That's usually how long she does, and it's kind of an intensive counseling, but she really goes at the child's pace. If the child is not really wanting to open up, then she does a lot of rapport building, or if they're able to jump in, then they'll work on that each week. And then they'll come up together with the trauma narrative, and that the child will basically read or tell the caregiver.
Right.
And I believe that I have never seen this personally, but I believe it's where they account what happened to them.
Yeah. Okay. And typically it's not. Is it the abuser, or is it just a non-abusing relative?
9 times out of 10, CPS has already intervened, and so it's a safe person for them to tell.
Yeah. Okay. And then I remember you saying that there was a mix of like age range wise, it's from, you know, wide range. Is there any times that she might use like a different modality? Like,
So she sees patients 7 and up. I think
Okay.
7's as low as she will go.
okay,
She does the TFCBT, and she's also started doing, I think it's called EMDR, where it's the eye, and she does.
yeah,
I've never seen her do it, but it seems like it's pretty neat. And she does that for more so, I would say, like a teenage age, someone who would be really patient through that. But
right.
she said she's had a lot of success
Yeah.
with it.
Cool. And then like with, let me see, like had a question when you were saying this. So with the intervention versus non-intervention, have you guys ever like followed up or noticed like the difference in like when a child has received therapy of some sort or an intervention of some sort versus like not?
Yeah.
Kind of. And yeah, is that something that you guys look at or?
Sure. You definitely have those examples of the kids who you've done intervention and they're open to the intervention.
Right.
And then they go through that versus kiddos where maybe they're still with their parents or maybe they're with relatives now who are kind of still like their parents. And there's the intervention doesn't happen. It's not that we're not giving it, it's that they're not following through. And then it's kind of like 51st dates where they come in here and it's almost like the same appointment that we had last time.
Right.
So usually with cases like that, we just try to be very consistent, and if needed, if things ever escalate, we definitely refer to CPS.
Right.
Just because, especially if it's ever any harm to a child.
Right. Definitely. And also, just curious, I guess, is there like any like, I don't want to say typical or standard, but like,
Sure.
like just like type or like physical abuse, like narrative, that sort of, like any themes that you noticed with that? I don't know if that
Meaning like where the abuse is on the body?
Yeah, or just how it came about, how long it's persisted, that sort of thing. Is there,
usually those things are caught like maybe with multiple hospitalizations, things like that. You can see it in babies a lot. Shaken baby's very common still. With shaken baby, they will have rib fractures that are also in the back of the ribs because they squeeze like this. And then they'll have possible brain injury.
Yeah.
And so basically from a child from 0 to 2, if we have a suspicion of physical abuse, we'll do what's called a skeletal survey, which is where we do, it's basically an MRI of the entire body, head, all bones, everything. And we do that at one point, and then we try to do what's called a repeat skeletal survey, which is the same thing but 2 weeks later, because sometimes injuries show up on the repeat exam rather than just the initial.
Interesting.
That is interesting. So whenever your bones heal, they calcify, and that calcification shows up more on an MRI than when they're broken.
Oh.
And so that's when you can see when they're healing. And sometimes you see the different stages of healing, so they were abused on more than one occasion, things like that.
Yeah.
So that's pretty common. We see a lot of what we call loop cord marks. So say it's like a mark that is kind of like a circle. It could be from a cord, like say a cell phone cord or whatever. Can be from a belt, things like that. I would say those are probably the most common injuries, especially in a like walking child. And definitely belt will be straight, kind of wide.
And yeah, I guess that was one of my other questions. Like, do you have you guys noticed like differences in the type of physical abuse that may occur for, like you mentioned, shaken baby for 0 to 2, and then is it like, oh, we normally see the loop cord in ages.
Right.
Is that something?
That's a little more common,
Okay.
you know, because any bruising or something going on with a baby that can't even roll over is very concerning because somebody's inflicted that on the baby.
Right.
You know, sometimes with kids that are walking, you get bruises like up your shin. Okay, they fell down.
Yeah.
But if they have anything on their torso or, you know, in areas where it's not normal to fall down, that's a little more common with those ages, I would say.
Right. And then would the same like sort of common physical abuse that occur maybe in like early childhood or childhood, like would you also consider those common, or have you seen those to be common in like adolescence and teenage years?
I would say like shaken baby, that's definitely only for babies.
Right.
But I would say physical could go all the way up.
Okay. Yeah.
For sure.
And then preventative, so moving on to preventative measures. So obviously preventative measures are like ideal, and we never want these things to happen, or for interventions or referrals to be needed. So what are does UT offer any preventative services, maybe out in the community?
Well, we definitely have our psychiatrist here. So if we have like an overwhelmed mom or a mom who has postpartum depression, we'll refer the parents here as well.
Okay.
And there is a program here, I can't remember the name right now, but it's done through the OB department where it's pregnant, high risk families. And they'll even like have a support group, which is pretty nice.
Yeah.
For our clinic, we do work a little closely with Depelchin, and a big thing that we'll do is a referral to their program Parenting Help, which is somebody to come in the home. Maybe we've seen something here where they're agitated with their child, or maybe their kids are just all over the place and they're just sitting there.
Right.
You know, Parenting Help is to just basically help with disciplining techniques and teach them about maybe a timeout or taking things away rather than spanking.
And then are you, is this the care clinic the primary referral source for that, or would a doctor or another person in the UT system refer?
They can.
Okay.
Yeah, it doesn't have to just come from here.
Right.
For sure.
Okay. Or are the steps usually like the doctor sees something, then they refer to here, and then you guys refer out, or is it?
It can be in other clinics.
Okay.
People know about that program as well. Sometimes we do get referrals from the other clinics just to see the family here, and then maybe say we will identify that as well.
Yeah. And then also on the preventative side, is there anything, maybe have parents ever come to you, or is there anything in place that you know of within the community that maybe parents have like said like, oh, you know, I was really overwhelmed and that this really helped me, or
I would say things like the PATH program are good. I've heard people talk about us like that. Sorry, I said PATH. Parenting Help. PATH is next door. They actually are an intensive program with a child who has like an emotional need, psychiatric, and also has to have a medical need. So that helps usually with education of the family. They also do a lot of counseling, family counseling, psychiatric services, and it's an intensive program every day for 4 weeks. And it also includes school so that the child, since they'll have to miss school, they can do that as well.
Yeah.
And I also want to tell you about whenever we have new patients here, we do what's called a SEEK form, and I'll give you a copy before you leave. But a SEEK form can identify different areas where a family needs help. So one of the questions is, I wish I had more help with my child. If they say yes, then that would clue me into, okay, so let me ask them a little more questions about this. Things about, I'm feeling depressed, I've had issues with drugs and alcohol, things like that. So that's a pretty good way to identify what their needs are.
Yeah. Do you ever notice, because I know like from our class, not necessarily from the readings that I've done for child physical abuse, but that drug abuse and addiction is like a major player in parents and child maltreatment. Do you find that I guess how do you find that like a parent who maybe is addicted to drugs, do they tend to be a little more like seeing more of the neglect or more abuse, or how do you see that played out, I guess?
I think it's more neglect, but it could easily be both. Think about it. If you have too much to drink, or if you've been using whatever drug, your mind isn't correct, and you're asleep, and now your baby's crying in the middle of the night, you're not going to wake up.
Right.
And so that's neglect because now your baby's missed a feeding.
Right.
It can also make you a little less patient, so maybe that leads to physical abuse. That's also, I would say, probably the easiest way to have your child taken from you is to find out that parents are on substances.
Right.
Especially when they're young. And also we've had kiddos come into the hospital or come in here and they've been exposed to drugs.
Right.
And so usually you can determine that through a urine drug screen test.
Like they've been exposed as in like they're not babies. Like they've done drugs.
Correct. Or like they've been exposed as in they've either ingested it or it's been around them.
Oh, okay. Yeah.
And so we will do a urine drug screen or a hair follicle. The hair follicle will tell a lot.
Okay.
And sometimes it's multiple substances.
Wow. Oh, whoa. I had no idea that you could do that. Like if it wasn't like the actual person doing the drugs.
Yes.
Yeah.
Yeah. So they will take samples of the child's hair on the outside and like right by the roots and test it, and that's usually where you can tell from months back.
Yeah.
What all they've been exposed to.
Interesting.
Yes. Yes.
Whoa. It's so interesting. And then I guess one more question related. I was just thinking about this when we were talking about like the parent. How do you notice like a child's attachment is even to a non-abusing parent? Do you notice any difference in maybe their attachment would be had they not been abused, or how have you seen that being affected?
Interestingly, it seems to be about the same. We had a patient here a few months back that mom brought the patient in. She had whip marks all up the back of her leg, and she was saying, oh, she just came home like that from the babysitter's house.
Yeah.
Attachment was great. Child was hugging on mom, you know, things like that. And we ended up probably just ordered.
Yeah.
The mom, we ended up sending the child to the hospital, and the mom ended up confessing that it was toilet training, and she was really frustrated.
Oh.
And it was interesting because we had a nurse at the time who wasn't used to child abuse, and she was like, but they're so bonded, there's no way this mom could have done this. And we said, oh no, that doesn't matter. And I experienced that when I worked at CPS as well. But something I noticed when I worked at CPS was there was almost a lack of attachment. Like the child would go to anyone.
Okay.
whenever I would remove a child, because, always in the movies you see this huge dramatic scene of, ripping families apart and things like that. It wasn't like that. The child would just go.
Yeah.
Which was very interesting to me.
Interesting. That's really interesting. I'm so glad I asked that question.
That's a good one. It's a very good question.
Wow. That's really interesting. And I guess just to finish up, what have you found to be the hardest part in working with children who have experienced physical abuse?
I would say the hardest part is sometimes when you know that they're at a very risky situation and your hands are kind of tied.
Mm-hmm.
And then that's when you just have to keep like a really close eye on them and advocate for them. And sometimes that just means advocating to CPS because maybe they don't see or they don't know.
Right.
And, it's just a lot of consistency.
Yeah. Yeah. Do you mean, like, when you say your hands are tied, meaning there's maybe not enough evidence?
Right.
Okay.
Yeah.
Okay. Yeah. That can definitely be hard.
Right. And sometimes, CPS, say, take a medical issue. That can be complicated. They don't know medical.
Yeah.
And so trying to explain that to them, and then they have to turn around and explain that to their supervisor, and then they have to staff that with their program director, or even legal, then now they have to take all the information that medical people have said and regurgitate it. And
they're not medical professionals.
Who knows what comes out.
Right.
So we try to work pretty closely with them where we give them all the notes from our office visits, from the hospital. That way they have all the tools.
Yeah, definitely. So cool. And then last question, what do you find to be the most rewarding part of working with children who have experienced physical abuse?
I have found the intervention. So it's kind of neat working here where we have seen kids long term. So say there was a child that came in over the summer, and I actually got them in because mom, how she was on the phone, I was just like, we need to see you.
Yeah.
And so came in, she was very inappropriate in the clinic, and we did a staffing with CPS where CPS wasn't going to do any intervention. They were going to leave the children home with her. And we pushed and pushed, and then they intervened. They were taken into foster care.
Yeah.
And the kids are doing great.
Yeah.
They are, thriving. They've gotten all the therapies they need, and they've grown a lot. And it's good to see like examples like that.
Right.
Where they're able to be okay, or even in cases where we're able to help the parents, and then the parents are okay and the whole family's okay. That's pretty amazing too.
Yeah, it's really cool. Well, thank you so much for talking.
You're welcome.
With me.
You're welcome.
I really appreciate it.
Sure. Thank you.
I've learned so much.
Oh, good.